As all of us know, COVID-19, the pandemic, has been ravaging the Philippines and almost all the countries all over the world, so suddenly turning our world upside down. We are faced with anxiety, insecurity, uncertainty, apprehension, and frightening emotions. We are compelled to embrace changes as persons, as community members, and as institutions. We do this to live as normal as possible, even in a not-so-normal situation. The new normal is our reality now. Perpetual Soccer Hospital, here, we pool our efforts and acts together as one united body, assuring the continuity of quality, safe patient care that we have always committed ourselves to render to our patients, pandemic or no pandemic, thus gaining their full trust and confidence. Perpetual Soccer Hospital, through the Cebu Cancer Institute, from its foundation, has always been in the forefront of cancer care. The threat of disruption of treatment and care has allowed medical and allied healthcare professionals to seek for opportunities to innovate and modify treatment plans to ensure patients, especially with chronic illness like cancer, of a continued treatment and care through a less aggressive approach. Hence, it is deemed necessary that continuing education and research are carried on dynamically and consistently. Again, it is with great pleasure that I warmly welcome you all to Perpetual Soccer Hospital Cebu Cancer Institute webinar series on multidisciplinary cancer management, a treatment continuum. I wish to express deeply how grateful I am to our distinguished speakers from Singapore and the USA, whose time and expertise they are generously sharing with us. Perpetual Soccer Hospital is doubly blessed with the presence of committed, competent, and compassionate medical and allied professionals leading the Cebu Cancer Institute. They are the men and women behind this webinar series, ascertaining the smooth flow of the event and the successful interchange of knowledge and experience among all the participants. May this initiative bring forth fruits of innovation, scientific analysis, processes, and approaches in cancer treatment and care, ensuring the safety and being of our patients diagnosed with cancer. Thank you very much for your kind participation. May God bless us all, and may the Holy Spirit enlighten us, endow us with wisdom and full understanding. A pleasant afternoon to you all.
As you can see, the safety in terms of surgical, the time to surgery is the same, median hospital stay is the same, post-op morbidity was about the same, and post-op mortality was also about the same. So there's no differences in the safety aspect of the surgery. What about the pathology findings? You can see everyone, the P factor is significant, with a massive reduction there's massive reduction in the downstaging of the tumor compared in the TNT arm compared to the standard German rectal trial protocol. There was improvement in the 3-year disease-free of about 7%, from 68.5 to 75.7%. In the metastasis-free survival, again, there was also about a 7% difference, from 71.7% to 78.8%. In terms of quality of life, there was not much difference. In fact, for impotence, you find that the group that had the TNT arm was significantly lower compared to the standard arm. So they concluded that upfront chemotherapy with FOLFIRINOX significantly increased the probability of pathological complete response. It increases the probability of curative intent surgery, improved the disease-free survival, as well as the metastasis-free survival. The global quality of life scores were not significantly different between the groups, but support the FOLFIRINOX arm over time. All right, so that was their conclusion. So as I mentioned, the 3 years disease-free survival improved by 7%, and the 3 years metastasis-free survival also improved by 7%. Next, we will talk about consolidation neoadjuvant chemoradiotherapy, where the chemoradiotherapy was given first, followed by the chemotherapy, followed by surgery. There are 2 randomized trials. One is the Polish 2 trial, and the second one is the Rapido trial. The Polish 2 trial essentially had a short course radiotherapy followed by 3 cycles of FOLFOX, followed by surgery. Whereas the standard arm was that of something like the German trial, but instead of 5-FU, they included 5-FU plus oxaliplatin. The RO resection was 77% in the radiotherapy, then chemo arm, compared to the standard 71% in the standard neoadjuvant chemoradiotherapy arm. There was no difference in the disease-free survival, distant metastasis, local regional recurrence, and post-operative complications. The overall survival was improved in the radiotherapy, then the chemo arm, by also about 7%. The other trial that was published, presented at ASCO this year, is the Rapido trial. The study design is as follows. The standard arm is that of the German Rectal trial, where they are given 5.5 weeks of chemo with radiotherapy, followed by rest, surgery, and then after about 6 to 8 weeks, they carry on to another 24 weeks of chemotherapy. The experimental arm, the patients were given a 5-day course of radiotherapy, followed by chemotherapy for 18 weeks. Subsequently, they went on to go for surgery. The results does show that the RO resection was similar in both group arms, but the complete pathological response was much higher in the experimental arm, 28.4 versus 14.3%, and this was statistically significant. The disease-related treatment failure was also improved by about 7%, from 23.7 to 30.4%. The distant metastasis again improved from 20 to 26.8%. The local regional failure was equivalent. The overall survival was similar. And the quality of life at 3 years was essentially quite similar in both arms. So again, this trial does show a 7% lower disease-related treatment failure, 7% lower distant metastasis. It doubled the complete response from 14 to 28%. The 3-year overall survival was 89% in both groups. There was no unexpected toxicity, and there was no differences in surgery, post-operative complications, as well as the quality of life. So these 2 trials have showed us that giving the chemo before surgery at systemic doses does reduce the risk of metastasis. So it's finally a proof of principle and is approximately 7% in both trials. Okay, so the last total neoadjuvant therapy approach is that of organ preservation. That means you give the induction or consolidation neoadjuvant chemoradiotherapy, and then we go on to a watch and wait approach if the response was good. As you all know, the morbidity of any rectal surgery is about 38%. There's a 2 to 3% chance of mortality. There's a 20% chance of urinary dysfunction. There's a 15% chance of sexual dysfunction. There's also problem with fecal incontinence, about 20%. Requirement for APR is more than 10%. More than 50% of the patients required a stoma. And the recurrence rate was between 8 to 40% depending on the trial. In a study on the quality of life, 167 patients after colorectal surgery responded to a questionnaire. And to these people, the most important for his quality of life is not having a permanent stoma, about 78%. They were more concerned about not having a permanent stoma compared to 76% who want to be cured of the cancer. And of course, 74% hoped for no complication. What is least important for the quality of life is what kind of surgery was done, what's the length of stay, what's the incision length. So this is the same, it's just graphically to show you that the most important to patients is not having a permanent stoma and being cured. And having no complications. These are most important to all the patients who were surveyed. So what about organ preservation? That means to watch and wait without doing any surgery after a complete clinical response to chemoradiotherapy. As mentioned earlier, the chance of having a complete clinical response is about 20 to 38%. It all depends on how long you wait after you after you're completing your chemoradiotherapy. So there are many small studies and a meta-analysis have shown that there's no difference in the oncological outcomes between watch and wait versus surgery. There's always 3 years regrowth rate of about 22%. And nearly all, about 90%, had an endoluminal component when they start regrowing. And there was no difference between the incidence of metastasis in people who watch and wait versus surgery up front. So, but those are all small studies, and there's no randomized trial. So there is this trial that was presented at ASCO this year. It's called the OPRA trial, Organ Preservation Trial, Rectal Cancer Trial, where patients are randomized to a consolidation neoadjuvant approach versus the induction. Then they are restaged. If they had no clinical response, they actually went on to go for surgery. However, if they had very good, complete clinical response, they were offered watchful waiting. Okay. So in their follow-up protocol, in the watchful waiting, they actually had a sigmoidoscopy as well as CE examination every 4 months in the first 2 years, 6 months in the subsequent 3 years. They required a rectal MRI first 6 months for the first 2 years and 12 monthly next 3 years. They also needed a CT abdomen, chest, abdomen, and pelvis every year for 5 years. A colonoscopy was performed 1 year after diagnosis and the guidelines thereafter. All right. As you can see, the disease-free by treatment group was the same. The metastasis-free also by treatment group was the same. However, we did notice that the TME-free, that means no need surgery, was higher in the consolidative neoadjuvant chemoradiotherapy arm. This is still in the early stage and we are still waiting for the full results, and we need longer follow-up for this approach. So in summary, preoperative chemoradiotherapy or short course radiotherapy are the standard of care since the 200s. However, distant metastasis was a problem, likely due to low compliance to post-operative chemotherapy. Giving total neoadjuvant chemotherapy is feasible and safe, and this results in a higher compliance to the systemic chemotherapy. Total neoadjuvant therapy does not compromise local regional recurrence, and it improves disease-free survival and distant recurrence by 7% compared with the current standard. We await the overall survival data of the Rapido and the Prodigy trials. A watch and wait approach, if patient had complete clinical response to initial chemotherapy, is an option for the patient who refused abdominal perineal resection, just like my patient, Mr. Y. We are also waiting for the full analysis and mature results of the OPERA trial. So as you can see, in the locally advanced rectal cancer, we need to adjust various dials for the radiotherapy, the systemic therapy, as well as surgery to achieve the outcome that we want, optimal outcome for the patient. Thank you very much for your attention.
Thank you, Dr. Fong, for that wonderful lecture. Our second speaker is a colorectal surgeon from Parkway Cancer Center in Singapore. He is also an adjunct associate professor from the Yung Lon School of Medicine in the National University of Singapore. He is also the past president of the Singapore Society of Colorectal Surgeons, a fellow of the American Society of Colon and Rectal Surgeons, a visiting consultant in Singapore General Hospital, and a visiting professor for the Advanced Laparoscopic Colorectal course at the Research Institute Against Digestive Cancer, both in Sichuan Healthcare System and in the European Institute of Telesurgery. To give us a talk on surgical management of rectal cancer, help me welcome Dr. Dean Chi Siong Ko.
I want to thank Dr. Ali and Dr. Fu for your kind invitation to speak to you today at the Cebu Cancer Institute webinar. Good afternoon, ladies and gentlemen. I will be speaking about the current techniques of sphincter salvage surgery in the treatment of rectal cancer. Do note that rectal cancer involves the lower part of the colon, extending from about 3 centimeters to 15 centimeters from the anal verge. Cancers involving the anal canal are different and are not covered in today's talk. The abdominal perineal resection has been described more than 100 years ago by Dr. Ernest Miles and still remains relevant today. However, because of the presence of a permanent colostomy, quality of life effects have made this not an attractive option in this modern day. What has led to the decrease in APR rates has been a better understanding of margins, the technical advances in the form of staples that have been made available today, the knowledge of the various reconstructive means with good functional results. Over the past 10 to 20 years, the use of multimodality chemoradiation has allowed us to shrink the tumors to enable us better clearance. And of course, the current standard of total mesorectal excision has been well expounded. Now, the goals of surgical treatment is simple. We need to clear all the potential tumor margins, proximal, distal, as well as circumferential. And then we need to restore the bowel continuity with a tension-free anastomosis. Proximal margin is never an issue because division of the IMA would render the sigmoid colon not viable, and therefore that needs to come out. So proximally, that will not be an issue. For distal margins, I think the studies have shown that the distal intramural spread extending more than a centimeter does not happen commonly, in less than 10%, and therefore a 1 centimeter distal margin is acceptable today as an oncologically safe margin. Now, the circumferential margins have become very important because they have clear data to show that involved CRMs correlate with the presence of local recurrence. Now, what is the circumferential margin? It's essentially the outermost distance of the tumor to the resection margin, which is the TME plane, shown in blue. This is inside of the neurovascular bundle of Walsh, which is important for bladder and erectile function, and therefore the non-VAS fascia becomes important during surgery. The circular staple has made ability to restore bowel continuity so much simpler today as compared to the sutured anastomosis of old. The end-to-end staple just allows for increased sphincter preservation procedures in low rectal cancers, therefore limiting APRs only for selected cases. It's important to note that sphincter salvage surgery involves a good understanding of the role of the internal anal sphincter and the external anal sphincter in the maintenance of continence. Now, good imaging with MRI is now standard for all rectal cancers, and this allows us not just to stage the tumor locally in terms of depth, it also allows us to measure the distance of the inferior edge of the tumor from the sphincter complex. Now, which patients are suitable for sphincter preservation? It's important to note that patients with preoperative poor function like incontinence and diarrhea are not suitable candidates. As far as tumor specifics are concerned, the tumor needs to be no more than 1 centimeter away, or more specifically above the anorectal ring. Large tumors would make it very difficult to achieve a good margin. Poorly differentiated tumors, bad histology are essentially no-goes for sphincter salvage, and metastatic disease is essentially a contraindication. For the operative technique, the pedicle ligation is quite standard. Division of the IMA either in a low tie or a high tie fashion has been shown to make no difference. What is important is the oncologic clearance. If one performs a low tie and only clears the lymphatics and the lymphatic tissue up to there, you're potentially omitting clearing the lymph nodes at the root of the IMA and therefore understaging the patient. So the ideal clearance of all the lymphadenectomy should involve this. Now I'm just going to show a quick video on how we perform the ligation in this day and age, and of course with a minimally invasive approach. The key is to stick close to the inferior mesenteric artery, like what I'm doing here, dissecting it as and the reason is simple. You can see that the nerves in white are very, very close by. So if you stay away from the artery, you will be potentially dividing all these nerves, and when you divide those nerves, you will have some impact on your autonomic function. Here I'm skeletonizing the IMA using a bipolar device called the N-seal, and once you have done that, and you can see the nerves down below which are safe, it's a matter of using hemolock clips or any form of clips to divide the vessel. Here with the hemolock clips in place, I'm electing to use the bipolar device to seal and then to divide the artery. The IMV needs to be taken high because that's the only way you're going to allow the colon that you have divided to come down to the floor of the pelvis for your anastomosis. So I typically take them at the DJ junction. That's the vein. You saw the DJ flexure earlier, and then division is the same as for the artery clips, and in this case I'm just using a scissors to divide it. Okay. Now, of course, with a robotic platform, the dissection and the division is identical. The left upper video is the IMA, the dissection and division. The right lower video is the IMV division. So you can see the dissection is the same. You stay close to the artery and the vein, and then you clear all the lymphatic tissues off. That will come up with the specimen, and then division is either with clips or with the energy device. Once you've divided the vessels, then it's medial to lateral dissection, and this is freeing the mesocolon and the colon of the retroperitoneal fascia. Here I'm showing you the robotic technique of doing so. Arm number 3 is lifting up the mesocolon, and here my 2 arms are allowing traction, counter traction to display the plane. So the mesocolon is being pushed upwards, and the retroperitoneal fascia is being freed from it. If one stays in this plane, the left ureter and the left gonadal or ovarian vessels will always be safe, as you can see here. Okay. Once you've done that and you've completed the medial to lateral dissection, then the division of the lateral attachments and the takedown of the splenic flexure becomes very simple. Here I'm doing this laparoscopically, and what you are going to see here is that you medialize the colon. Once you medialize the colon, here I'm using the NCU bipolar device, which is very quick in cutting and dividing, and you will soon see that I will join the medial to lateral dissection that I had performed earlier. Okay, so there you go. Just pulling it medial, and you can see there. So what's below my instrument would be the medial to lateral dissection that had been completed.
Plane between the parietal and the visceral layers of the pelvic fascia can be identified at all levels. Here, the dissection begins just over the sacral promontory, entering the retrorectal space.
It's still very relevant today. The technique is
dissection continues bloodlessly down the retrorectal space.
Pretty much similar to what we're doing using the minimally invasive platform, and it's encouraging that to note that even he supports all the minimally invasive methods that we are using to perform exactly the same type of operation as he is. Right, so this is your TME all the way down to the pelvic floor, and then division right there. Bear in mind that the 2 parts of potential nerve damage can occur. One is at the sacral promontory, where if you go too deep, you may damage the hypogastric nerve bundles, and during the dissection around the prostate and the seminal vesicles, if one goes too anterior, then you might damage the pelvic plexuses. So this is a quick video showing TME using the robotic platform, and you will realize that it's very, very similar in what you see Professor Heald perform using the open technique. Now again, instead of the St. Mark's retractor, you have your robotic arms performing exactly the same function, and this displays the angel hair appearance when you are in the right plane. So this is the upper part of the sacrum dissecting, and when you are in the right plane and with the right traction, you will realize that you actually do not need much energy. You can even use the sharp scissors to do this, but of course with the instrument that you have here, it is both cautery and scissors at the same sitting. Now you notice that I am staying anterior to Waldeus fascia. You can see the vessels and the nerves deep to that fascia in front of the sacrum. Now staying close to the mesorectal envelope, but not breaching the mesorectum. That is the key to this. So how I do this is to go as far caudal as I can with in the posterior plane, and then once I've completed that, I come round to the right anterior lateral plane here, and the first structure that you see when you are in the right plane will be the seminal vesicles, which you will see appearing very shortly. Okay, so there you go. In the right plane, seminal vesicles appear right there, and you can see the angel hairs that guide you into where your planes should be. Staying behind the non-VAs, you will minimize potential damage to the neurovascular bundle of Walsh, as you can see here. Okay, so once you have joined the right anterolateral to the posterior, then it's a matter of coming down to the left side, as you can see what I'm doing now. This is the left side of the mesorectum. Notice how the endo-wrist function of the robot allows one to get a very nice angle, even though the instruments are coming out from the right side of the abdomen. Okay, so that will lead you down close to the floor. You can see a hint of Denon-VS fascia there, and you notice that I'm staying posterior to that fascia. Okay, right. It's important to note that if you want to go down as far or as close to the pelvic floor as possible, you need to divide the rectosacral ligament, which is usually a fibrous band that you see here, what I'm demonstrating. This is the attachment of the distal rectum at the anorectal junction to the sacral coccyx. That's that band that you see here, and you need to divide that band, because once you divide that band, it creates that space that allows you to straighten the rectum completely off the pelvic floor and allows you to place the staple there. Now, distal transaction usually is in the form of transverse staples like this. As you can see, this is very commonly done in the open setting with a clamp and the staple, and this is what we'd like to achieve, transaction flush with the pelvic floor. This is the contour device that you can see inserted laparoscopically. The contour device makes it easy to divide the distal rectum in a very narrow space, because it only allows one device to go down. It doesn't allow any more clamps to go down like this. And then once you've placed the device as far distal as possible, as you can see here, notice how there is just no space to put anything else there, and then you divide the rectum. Okay, linear staples are mainstay in our armamentarium for laparoscopic distal transaction. This is the standard articulating linear stapler that I'm using to slide down in this narrow male pelvis, and you can see that the head is articulating. Okay, and then that allows me to slide that down distally as far as possible. Okay, and then once you close the jaw, you can fire the staple. In most instances, 2 fires are required to divide the rectum, as you can see here. Nowadays, we do use powered devices simply because it is more stable. All movements are mechanical. It's no longer by turning knobs. As you can see here, even the closure is mechanical. There you go, it's the closure. Once it's closed, once you're comfortable, you fire the staple. You can see that the blade going across, the blade is coming back, and there you go, the division is complete. Of course, the ideal one would be the robotic endo-wrist stapler, which is shown here in the XI system. There is good articulation, 108 degrees side to side and 54 degrees up down. This is as good angulations as you can get, better than any mechanical staples. And of course, you have the smart clamp technology that senses the tissue thickness and tells you whether it's safe to fire the staple or not. Now, for patients whom it's too difficult for you to put the staple down, then it's a transanal division, like what I'm doing here. This is the Lone Star retractor that we place to efface the anus, and then with direct vision we divide the rectum at the anal rectal junction. I like to use these S retractors to retract the tissues for better visualization. As you can see there, once you've divided and you've completed your TME, it is actually fairly easy for you to exteriorize the entire rectum and colon, and then you can divide that colon extracorporeally and perform your anastomosis. Now, intersphincteric dissection is actually critical today now because this allows us to go even further down than what we are able to achieve. So, for example, if you have a tumor there, a partial intersphincteric dissection is possible to achieve clear margins. If you have a lower tumor, then a total intersphincteric dissection can be performed because you are leaving behind the external anal sphincters. Of course, if you have a tumor there involving both sphincter complexes, then sphincter salvage is not possible. Once you've divided it, then bringing that proximal colon down into the anal canal and performing a hand-sewn anastomosis is not difficult. The best video instructional that I know of is this one shared with me by John Marks from Pennsylvania. They have perfected this technique. Here you're making the using cautery to mark the point of dissection or transection, which is at the dentate line, and then using cautery to incise the mucosa. Once you've incised the mucosa, this is what he advocates. You need to use the scissors, and you open the jaws of the scissors to accentuate the plane. There you can see the external sphincter muscle and the internal anal sphincter muscles. So you are going in between the planes. Okay. Then you use the Alice clamps to lift that up, mucosa and the muscle. And notice how you slide that scissors in, spread it, and that gives you the plane to go. Spreading function. Okay. You can see the two muscles separate, and then you divide them. Okay. The most recent techniques of division involves the transanal TME or TAR TME, and this is not to be performed easily simply because there's a very steep learning curve and there are potential damages which I will not go into detail today.
Now, I'd like to
best
step-by-step
instructional
procedures
video
of
comes
TME
from
coding.
Professor Ito from Tokyo, who shared this with me when we were teaching in Strasbourg, and this
And
is just to
then,
give you a quick
to avoid
preview of
cancer
what it's
cell
like.
dissemination,
So
we
this
made
is the
purse
division.
string suture like this.
This is the purse string placement for you to occlude the anal rectum.
Side.
And here
We
what
start
he's doing
dissection
is
in
from the
5 o'clock
transanal approach
to
using
enter the
minimally
surface
invasive
of
platform.
levatorary muscle.
He is dividing
This
the
fiber is
distal
derived from
transaction point,
outside.
and then heading in a capillate fashion.
We go
perform
to
TME.
seminal vesicle
Here is
level.
Anterior. and
Here
he's
is
stepping
close to the
prostate
peritoneal
away
reflex.
from the mesorectum that he's pushing
We
down
go
with
back
his
to
left
posterior
arm. This is the
dissection.
posterior portion.
By
As you can
stretching
see,
up the rectum, we can
it's a
identify
slightly
the
different skill
accurate
set.
dissection plane.
So what is the role of chemoradiation? It is this: if you have lesions that are close to the sphincter complex, that are potential candidates for salvage, chemoradiation would allow for shrinkage of the tumor, therefore allowing better clearance and potential intersphincteric dissection. For restoration of bowel continuity, it's either staple or hand sewn. For staple anastomosis, this is quite standard using an EEA staple, end-to-end staple. This is a very, very low anastomosis that I'm performing here. You can see the levator muscles and the spike coming through the anal canal, and then just hooking that up with the proximal staple, the anvil. Notice again that the anastomosis has got to be tension free, like that. Okay, you can see the thin white lining of the vagina just in front, and then keep making sure that you don't inevitably staple the vagina. Okay, so reconstructive techniques. Most commonly, I perform a straight coloanal anastomosis. If you want to create a reservoir to improve function, then a J pouch is a alternative. The transverse coloplasty is no longer in favor because of significantly higher leak rates, and this is also what I like to do commonly is the Baker type side to end anastomosis, which gives you a little bit more creation of kind of a space for a reservoir. TME is not without morbidity, and of course the most significant morbidities include anastomotic leaks, together with a low anterior resection syndrome and sexual dysfunction. I tell all my patients where we are performing sphincter salvage surgery that LAR syndrome is a definite significant issue that they have to be faced with. They can get fragmentation, urgency, and varying degrees of incontinence, and the pathophysiology of this has been well described. So essentially what is happening is that the neo-rectum is not the same as the original rectum. Bladder dysfunction has been reported up to 20%, and impotence as high as 30%. So all these need to be described and discussed to the patient. And it's because of all these that organ preserving strategies are now in vogue, as Dr. Fu would have mentioned, the watch and wait technique. There are certain criteria to consider that right now because it's not standard of care in our setting. There must be evidence of clinical complete response, and the criteria for clinical complete response would involve endoscopic criteria, clinical criteria, as well as imaging criteria in the form of MRI, using both T2 weighted as well as diffusion weighted imaging to determine that there is complete response. There's a lot of data coming out from Sao Paulo in Brazil, from Angelita Habagama, but gradually there's more and more data coming out. All in all, there's good local control rate after 2 to 3 years. Disease-free cancer-specific survival so far has been quite acceptable at 3 to 5 years. Overall survival, high percentages after 3 to 4 years, and most importantly, colostomy-free survival of up to 80% or more at 5 years. Now, these patients need to be on very, very close follow-up every 3 months in year 1, and 3 to 6 monthly in year 2 and 3, and then 6 monthly in years 4 and 5. This is what is recommended. And the reason for that is very simple. This is Angelita's data, which shows that there is a regrowth rate of almost 25% at 3 years. So in summary, rectal cancer does not mean a permanent colostomy. We all aim for sphincter preservation as a goal these days, but it's important that we do not compromise the oncologic clearance And to do that, accurate preoperative staging is essential, and a wide use of neoadjuvant therapy for downstaging is currently the norm. It's important to note that high volume surgeons do make a difference, and the data has proven that. Thank you very much for your kind attention.
Thank you for the comprehensive lectures, Dr. Fu Kian Fong and Dr. Dean Ko. To facilitate the question and answer portion, we'll turn you over to our moderators for the open forum discussion.
We now open the question and answer session. If you have any questions, you can type it in the Q&A button or chat box, and we can address it to the speakers. So we have one question here, Dr. Fong, Dr. Ko. How do you determine complete clinical response if you choose the watch and wait option?
Okay, I think Dean has answered the question in the last part of his lecture. It's actually a process of clinical examination, a scope, as well as MRI, as well as the PET changes. So we determined all that based on all the findings. So in the clinical examination, there mustn't be any leftover nodules, no leftover stenosis. And then, as Dean mentioned in his talk, the MRI changes that we looked at to tell us whether there is response or not. So based on all this, plus the PET scan, we will decide whether a patient has a CCR or not.
Dr. Dean?
Yeah, I think Kian Fong has described it. There is a additional classification for tumor regression grade. That is, of course, based on pathology. But certainly, it's important to complete the evaluation thoroughly. And as clinicians, we have to be fairly confident that there is a clinical complete response before we offer the patient the watch and wait alternative.
Thank you very much. We have a question from a medical oncologist, Dr. Matthew Yap. He is asking, which is a better outcome between induction neoadjuvant chemotherapy and consolidation neoadjuvant chemotherapy, and which do you prefer? I think this is for Kian Fong. And there's a follow-up question. With Rapido trial, can we give neoadjuvant CAPOX regimen for 4 cycles instead of 6 cycles, followed by TME surgery?
Okay, so I guess both questions are to me. In a situation like the Rapido trial versus induction versus consolidation, I think the only trial that is being done is the OPERA trial right now, comparing the induction as well as consolidation. We only have the preliminary results. We don't have the final results. So based on the preliminary results, the consolidation chemotherapy seems to offer a better chance of having watch and wait. But the final outcome, we need all the overall survival and all the other results before we can decide which is better. As for his question about 4 cycles versus 6 cycles in the Rapido trial, a lot depends on what he's trying to achieve with the chemo. So if he's thinking of, sometimes we cut short the number of cycles if the patient has a lot of side effects or they cannot tolerate, or clinically he thinks that the patient is actually not responding to the treatment. I guess 4 cycles is not wrong to give 4 cycles. But if he's thinking of controlling the cancer, thinking of reducing the risk of distant metastasis, then I think he should complete the 6 cycles of CAPOX.
Thank you, Kian Fong. And I think there's another question in the chat box. What is the recommended diet for post-sphincter salvage surgery? So I think this is for Dr. Dean Ko.
Yeah, that's a very good question. I think even before you start talking about recommended diet, it's management of expectations when you're going to offer sphincter salvage surgery to your patients. And the analogy I like to use is what I learned from Mark Whiteford from Portland, Oregon. He tells his patients, and I do that myself. So when you end up removing the rectum, what you're doing is you're removing a smart rectum. The smart rectum can sense
It has a reservoir, it has capacity, it can tell you when you need to go to the bathroom. Now we're going to replace that with a neorectum made of a not so smart colon. So no matter what you do, it's not going to be it's not going to be the same as what it was before. So I tell them that you can't expect your function to be the same as what you did before surgery. I give them the different possibilities or different presentations of what we call the LAR syndrome, LAR syndrome, which is fragmentation, frequency, sometimes difficulty in holding, a little bit of incontinence symptoms. And I manage that. I tell them that the worst timing would be the first 2 years. It usually takes about 2 years for this to stabilize and for them to get a consistent habit that they may be used to. They may require medications to control their function, such as stool, either laxatives or slow medications to slow the transit time. Only after that, then I go down to diet. So the diet that we recommend really depends on what kind of functional issues they are faced with. So you can have, I don't think you can prescribe a very specific one size fits all kind of diet. It really depends on what they need. Some patients require more bulking, so fiber. Some patients, if you prescribe fiber, they're going to be immensely constipated. So some of them require softness. So it's something that you have to tailor based on what their problems are or what their issues of function are after the surgery.
Thank you, Dr. Dean. We have another question from Dr. Anko, a radiation oncologist. What's the most frequent grade 3 adverse effect you see following chemoradiation in your practice? And a follow-up question would be, if you see grade 3 colitis or protracted bleeding following chemoradiation, if you still do, how do you manage this?
Hardly see any grade 3 colitis or any bleeding. I actually haven't seen any. The most common adverse events that we normally see are like, having cystitis. And then they do have some diarrhea, but never grade 3, maybe grade 1 or 2. So most of the time and then of course skin changes related to the radiotherapy. Here I'm talking more of the long course chemoradiotherapy. But we hardly see any grade 3. And the main reason is because pre-op, most of the time, the bowels have not flopped into the pouch of Douglas. So normally they don't affect the small bowel. The colitis or the enteritis is usually very mild. So most of the time we just give them diet, give them things like Imodium, and then dress the wounds and all that. Most of the time we get away with that without any interruption.
Mm-hmm. I guess that's the same question over here with regards to short course and the long course RT followed by TME. There's another question with the Rapido trial protocol for rectal CA with synchronous resectable liver metastases. So can it be applied? I think that's for you, Ken Fong.
Okay, that's a very good question. I guess we can give the chemo, the radiotherapy chemo first, and then we assess both the mets as well as the primary organ. But usually in Singapore, we stage the surgery. So either the mets is removed first, then the primary. Very seldom we do both together because my liver surgeons always say the rectal part is very dirty. They don't want to contaminate their field. So we usually separate both. We never do it together.
Mm-hmm. And also for Dr. Fu Kian Fong, your thought after a downstage pre-op stage 3 rectal cancer after a good TME surgery.
Sorry, I can't hear you, Amy.
He was asking what are your thoughts after a downstaged preoperative stage 3 rectal cancer after a good TME surgery?
What she's saying is there a need to go for any adjuvant treatment, is that?
Yes, I think that's it. And that's actually similar question to another surgeon, where do you give routinely the adjuvant treatment after a good TME surgery after a neoadjuvant? Yeah.
We still do, because it's based on the trials. Most of them we actually continue to give another 4 to 6 cycles, depending on how many cycles was given pre-op.
Okay. Louis, do you have any questions for Dr. Cole?
Dr. Ko, we have a question from Dr. Joseph Fuentes, Joboy. Which is now your go-to for mid to low rectal cancer? LAP, robot, or TATPE, organ preservation?
It's a good question. It really depends on your practice, because in Singapore, we almost never the open approach is almost restricted to cases where it's either emergencies or for whatever reason the laparoscopic approach is not suitable. Now, if you ask me if I had a choice, I would like to use the robot for all rectal dissections. But if push comes to shove, then you can use the laparoscopic approach for upper rectal lesions quite comfortably, where you are performing a wide, or what we call a tumor-specific mesorectal excision. But if you have to perform a total mesorectal excision, where you have to go down to the pelvic floor, then the robotic platform just allows you to do that a lot more comfortably. Be that as it may, I think in female patients, the advantage you get with the robot is not as pronounced as in male patients, simply because you have that narrow pelvis, and especially if you have a heavyset male, you still can do them laparoscopically, but it is painful after you have used the robotic platform. That's my simple answer.
And that's another question.
Oh, yeah, I'm sorry, I forgot. The watch and wait. Yeah. I think the watch and wait in Singapore is still not a standard of care. It is something that I discuss with the patients if there's a strong resistance to proctectomy. But I'm not sure what Kian Fong's experience is. I can't routinely discuss this with every patient, because it just adds to the confusion. It is already very complex because we have to tailor the treatment for each individual. And then when we throw in the watch and wait option, it just sometimes gets overwhelming for some of them. I don't know. Kian Fong?
Yeah, so usually I also will discuss the options. And we always tell them that in the watch and wait, there's always a 22% based on the Angelitas data of recurrence every year. So whether they can live with it, and whether they for most of them, they want to be cured of their cancer. But there is this small group, especially the men, they do not want the stoma, the colostomy for whatever reason. So some of them, like this particular patient that we presented, he just doesn't want a permanent stoma. So he actually opted for this surgical treatment or a watch and wait approach.
And I guess we can entertain one more question. Louis? There is a question here. Do you recommend DNA sequencing for possible targeted treatment together with your chemoradiation?
Okay, we do routinely, a lot of the surgeons, people like Dean and some of the other local surgeons, when they do a biopsy, the pathologist will reflexively do some of these gene tests, like the KRAS, NRAS, the MSI. But you see, we don't have any data per se that, with this, whether we should add in the targeted drugs, like Erbitux or whatever. So at this point in time, is good to know, but I wouldn't use it unless, there's maybe a MSI that's very high, there's maybe we can give immunotherapy, something like that. Then we can discuss with the patient.
Okay. Thank you very much. And I guess, Louis, do you have any more questions?
I have one question for Dr.
Okay.
Dean. What would you recommend as imaging modality after neoadjuvant treatment for patients for possible sphincter salvage surgery?
Oh, um, when they have completed their chemoradiation, number one, we are now waiting for a longer period or interval before we perform the total mesorectal excision. I think 15 years ago, 6 weeks was quite a standard interval that was accepted. I think the data now shows that the longer you wait, the more response you are likely to get in terms of downstaging. So we are pushing that to 8, 10 weeks, sometimes even 12 weeks before we perform the surgery. So depending on the response that we are getting. Now, we have to evaluate them clinically for sure. Digital rectal would give me an idea how far the tumor is from the sphincter complex. An MRI is absolutely essential because that tells me the circumferential resection margins. Okay, it allows me to determine whether it is abutting the sphincters, it is clear from the sphincters, it is involving the sphincters, because that really gives you the final answer on whether you can just do a straight TME without intersphincteric dissection, or you have to perform an intersphincteric dissection. And if you have to do ISD, whether you have to take the whole internal sphincter, or you can do a partial ISD. Now, bear in mind that the more you do, the more you take, the likely worse function the patient will experience after restoration, and I think that's important to discuss with them.
Thank you, sir.
I guess that's end our open forum. Louis, do you agree that ends our open forum? For any more questions, you can actually just email us and we will send them to Dr. Dean Ko and Dr. Fu Kian Fong. So thank you very much, gentlemen, for this wonderful afternoon. And that ends our open forum.
Thank you. Thank you very much.
Thank you.
Thank you. We are nearing the end of our foremost, our wonderful speakers from Singapore, our brothers from Singapore, Dr. Dean Ko and Dr. Fu Kian Fong. Kian Fong was like my brother at NCC. So thank you very much. And indeed, it is wonderful to be sharing, to be having this multidisciplinary meeting. First and foremost, to educate ourselves, because we are the caregivers, cancer caregivers, and to benefit all our cancer patients. And I hope this will be a long-lasting exchange of ideas within the Asia Pacific and with other countries as well. So in behalf of the Cebu Cancer Institute, Perpetual Soccer Hospital, thank you very much to our speakers, Dr. Loreto Ong, my co-moderator, and everyone who's involved in the concept and in the staging of this webinar series. And there will be more webinars, 3 of them actually, for the next 3 Saturdays. Thank you very much.
Once again, we'd like to thank our sponsors for making today's event possible. So for our platinum sponsors, we have OEP Philippines, we have Mundi Pharma, Bio Onco, Sandoz, Goodfellow Pharma. For our gold sponsors, we have Mylan and Calbe International. For silver sponsors, we have Camber, Hetero, and Novartis Oncology. And for our bronze sponsors, we have Detoxicare Philippines Incorporated. Special thanks to Roche,